So in the next 20 minutes, we're going to discuss the autoimmune disorders and the fetus, how it affects the fetus. So what are autoimmune disorders? They're a chronic, multi-system, and they're a huge group. They're heterogeneous disorders. And the immune system starts attacking your own cells, tissues, or organs, causing damage and inflammation. And these antibodies may be mediated through cytokines or T cell. And there are multiple clinical and lab aspects. So to divide the autoimmune disorders, we divide them into systemic autoimmune disorders and organ-specific autoimmune disorders. Here, the examples are rheumatoid arthritis, SLE, APLA, or microscopic angiitis. Organ-specific could be Graves, myasthenia gravis, diabetes, multiple sclerosis. So what happens in autoimmune disorders? There's a strong association between the autoimmune disorders and OPS complications, especially with certain conditions like SLE, antiphospholipid, and autoimmune thyroiditis. And the pregnancy may be unfavorable outcomes both in the mother and the fetus because of the disease itself. There may be disease flares. There may be uteroplacental insufficiency due to vasculitis. Or you may be using a lot of drugs for pain relief, for autoimmune condition. And there are always associated complications like diabetes and hypertension. So it's not just because of the disease itself, but the disease, drugs, associated complications, all these cause a lot of problems. There are so many conditions. I do not want to deal with all of them. Suffice to know that the prevalence of autoimmune disorders is about 7 to 9%. The incidence in pregnancies would be around 7 per 1,000. And because this affects mostly the reproductive age group mothers, we see them more often, and 71% may be multigravidas. So this is a pie diagram of the spectrum of diseases. And when the commonest condition that we would come across would be autoimmune thyroid conditions like Hashimoto's, which manifest most in the postnatal period, and it may manifest as both hypo and hyper. And if we do not correct it, we know there could be neurodevelopmental issues in the fetus. Then type 1 diabetes and idiopathic thrombocytopenia purpura are also common conditions. When we looked at our own conditions, medical disorders, we found the commonest conditions were Sjogren's, systemic lupus erythematosus, rheumatoid arthritis, APLA, undifferentiated connective tissue, and others. And the commonest morbidity in the mother was preeclampsia, eclampsia, and stillbirths. So how do we prepare these mothers for pregnancy so that both the mother and fetus are safe? Try to counsel them so that they plan the disease in remission, because the symptoms have to disappear or improve for at least 6 months prior to pregnancy. Do look at the drugs that you're using for hypertension or for their disease inflammation to see that these drugs are not teratogenic so that you balance the risk to the baby and the health of the mother. So what are the pre-pregnancy challenges and how do we counsel them? There should always be a pre-pregnancy consultation. Talk to them about the past and current disease activity, any pre-existing organ damage, what is the serological profile, is it anti-dsDNA, are the other antibodies present? What is the medication history? Any additional medical disorders, past obstetric history, and do some baseline tests like sugar, creatinine, LFTs, and other organ-specific. So what is the effect of pregnancy on autoimmune disorders? It could have a variable effect. There could be exacerbation or no effect, or there could be even improvement of symptoms like in rheumatoid arthritis when disease is mediated by T helper cells. So there are a series of effects on the fetus, and the list is too long. First trimester miscarriages, fetal death, preterm birth, congenital heart disease, low birth weight, neurodevelopmental disorders, hematological malignancies, or the fetus themselves may develop autoimmune disorders. So how do we monitor when the list is so long? Your routine first trimester, second trimester scans, and then timely surveillance and timely deliveries, and if there is IUGR, you would do a Doppler. What are the drugs in autoimmune disorders which can affect the fetuses? Look at all the immunosuppressive medications, and the list is so large that I will not be able to cover them. But look at each drug and see, is it essential to prevent active disease? Is this drug fetotoxic? Always, what weigh the risks versus benefits? This is the entire list. In fact, some of the medicines that these women take, and then you have to classify them as to, is this drug safe in pregnancy? Is there any data on that drug? Or are they high-risk teratogenic drugs? If the condition is antiphospholipid syndrome, then you certainly need to put the mother on aspirin, which we have heard is very safe. If she's had previous thrombosis, then, and if she's on warfarin, that's one drug we will have to change to aspirin and low molecular weight heparin. And these are then safe because warfarin can cause warfarin embryopathy. And this typically involves the face. There is nasal hypoplasia and stippling of vertebrae or bony epiphysis. There could be intrauterine growth restriction, or there could be brachycephaly. NSAIDs that many people use for pain relief may cause ductal constriction. So especially in the third trimester, after 27 weeks, it is recommended that they should stop these drugs. If they are on methotrexate, certainly it is not a safe drug because it can cause growth deficiency, microcephaly, hypoplasia, craniosynostosis. So most of these conditions affect the skeletal system and the face. So it's very important that if they have taken it, do a careful scan and also counsel them about these abnormalities. Mycophenolate, if they've been using, that's again an immunosuppressive drug. It is a teratogenic drug, and it can cause cardiac abnormalities, clefts, eye abnormalities, skeletal, kidney, and micrognathia. So very, very careful scan is recommended, including appropriate counseling depending on what you have found. These are some of the case reports of sonographic features of fetal malformations when the mothers were on mycophenolate. There is a facial dysmorphism with micrognathia, microtia, and bifid nasal tip. The adverse effects of SLE in pregnancy affect both the mother and the baby. So you need to stratify this mother when she comes to you, do the same pre-pregnancy counseling, see if she's had an active flare of disease, if her kidneys are affected, is there presence of antiphospholipid syndrome, monitor her blood pressure, look at her medicines and see that she uses safe medications like HCQ and glucocorticoids. And if she has APLA, then she goes on to heparin and aspirin, depending on the situation. There are multiple autoantibodies in a case of SLE. And depending on which antibody is present, they may have an effect on the mother and the fetus. Like if anti-dsDNA is there in all, anti-nuclear antibody, and that is estimated by immunofluorescence staining. This is commonly associated with nephritis and flare. What we are interested today is the SSO-Rho and SSB-La antibodies and anti-SMRNP cluster. Some of these are associated with neuropsychiatric disorders in the mother, so it's very important as an obstetrician to look at the type of antibodies that these SLE mothers carry. Anti-Rho antibodies are especially important because they can cause a lot of conditions like heart block, and we will discuss about heart block because these cross the placenta to cause acute irreversible heart block. And this heart block, depending on the degree, could be first, second, or third degree heart block. These heart blocks are life-threatening, they have a high mortality, and almost 50% are due to autoimmune disorders. If a mother is anti-Rho, anti-La positive in the first pregnancy, she may have about 2% chance, but if she's had it once, the chance that she would again have it in the subsequent pregnancy is about 18%. Apart from the heart, the lupus babies may also have neonatal skin rashes, pancytopenia, hepatobiliary disease, stroke, and autoimmune disorders in later life. The pancytopenia, hepatobiliary disease, and may subside with time, but the congenital heart block is permanent, and they may need a pacemaker. So, like I said, the recurrence after the first index case is about 18%, 21 in 5 die, more than 60% need a pacemaker, and they may also have late onset cardiomyopathy. So it's very, very important and vital for us to look at the antibodies that an SLE mother carries, and if Rho and La antibodies are present, we need to monitor the baby for congenital heart block. There are varied outcomes apart from the heart block, which are more and more expanding, right from endocardial fibroelastosis to cardiomyopathy. These antibodies can cross. Can we really prevent this? Yes, hydroxychloroquine, starting 400 mg started from 10 weeks onwards, can certainly help these mothers if they've had a heart block in the previous pregnancy. And the PATCH study has proven beyond doubt that the recurrence rate of congenital heart block was reduced by more than half when the mothers were started on hydroxychloroquine, 400 mg once daily starting from 10 weeks. And this is a very safe drug to be used in pregnancy. Now coming to autoimmune neonatal chondrodysplasia punctata and maternal lupus. Yes, there are other conditions depending on other antibodies which can be causing. So what is chondrodysplasia punctata? It is again a heterogeneous group where there is an abnormal developmental of the skeleton. And the hallmark of this is radiographic presence of abnormal islands of calcification in areas of endochondral bone formation. And this leads to premature closure of growth plates. So if you see, there are so much punctate calcifications at the end of femur. And where else can you look for these calcification? You may find it at the epiphyseal ends of the long bones. You will find it in the spine, the sacrum, and the coccyx appears calcified, ossified, or other cartilaginous regions that do not normally calcify, including the trachea and the rib ends. So is it always a cause and effect? Is it always that a case of autoimmune disorders will lead to chondrodysplasia? No. There are a lot of other categories that you have to remember and exclude these before saying that this is because of the maternal autoimmune diseases, because they may be because of inborn errors, disruption of vitamin K metabolism, chromosomal abnormalities, or maternal. So it is always ideal that you do a karyotype for these babies, exclude chromosomal abnormalities, and then say it is probably because of the maternal autoimmune conditions. And this is again a case where you can see there are a lot of punctate calcifications that you can see epiphyseal stippling. Associated features with this stippling could be a binder's faces, where there is midfacial hypoplasia or other calcifications like we have mentioned. There may be brachytachyphalange, they have very, very short fingers. And these cases are often associated with respiratory distress, cataract, sensory neural hearing loss, and developmental delays. So it's very important for us to a detailed counseling. Just because of the disease, it's not the medication, the disease itself can cause these abnormalities in the fetus. So how can you reduce these complications? We did mention the use of hydroxychloroquine, oral glucocorticoids, azathioprine, cyclosporin, and tacrolimus are very safe. They can be used to prevent or manage SLE flares. Adjunctive therapies, depending on what she has, like APS, you can use heparin. If she has lupus, then other drugs can be used, but supplement them with calcium, vitamin D, iron, and folic acid. What is the likelihood that a fetus will develop the mother's autoimmune condition? Yes, conditions like myasthenia gravis. The mother's antibodies do cause transient neonatal myasthenia. Congenital lupus, like we said, can be passed off from the mother to child, but it is a rarity. But they do have an increased likelihood that this fetus has a genetic predisposition for autoimmune disease as an adult. To conclude, pregnancy in women with autoimmune disorder is a complex clinical situation. It certainly needs multidisciplinary care. We need to do appropriate preconceptional counseling. See if the disease has been quiet. Look at the medicines, see what needs to be continued, what needs to be discontinued because of its teratogenic effect. When counseling them, all regarding medication do weigh the risk versus benefits of these drugs. The fetus may be affected either with the drug or disease, so they do need careful monitoring and surveillance. So intense maternal and fetal surveillance is needed, and timely delivery plays a very, very important role in improving the pregnancy outcome in these mothers with autoimmune disorders. Thank you.